All right. Well, thank you for the kind introduction. Today, I will present an interview study I conducted together with Karin Jongsma while she was still here in Göttingen at the department. And it included people with cognitive impairment, and the study focuses on their assessment of advanced research directives for dementia research. So the study was conducted with the support of Katrin Radenbach and Silke Schicktanz, so thank you also to them. As we heard in the previous sessions, especially yesterday, but also just now by Georg Markmann, there is an increased focus on prediction as well as on forms of risk reduction. So for a better understanding of the course of dementia and for the development of more effective diagnostics, therapies, but also risk-reducing measures involving persons with dementia in research is very important. However, one of the major difficulties of including persons with dementia in research is that due to cognitive decline, at a certain point, they become not fully capable of deciding whether they want to participate in research. And up until now, the international legal standard for including persons with dementia who are not able to give consent is to ask for consent of a legal representative. So this standard is broadly applied also for other groups of people with cognitive impairment, but has several flaws. For example, representatives often fail to accurately predict the patient's decision, and they can also perceive the responsibility of making the right decision as burdensome. So other means of including people with dementia in research are therefore being explored, and the use of advanced research directives, in short, ARDs, has become a prominent alternative over the past couple of years. So an ARD can, in theory, be considered an ethically sound tool that can give competent individuals the opportunity to express their willingness or objection to participate in clinical research for when they become incapacitated. So the moral authority of ARDs is thus derived from the principle of respect for a person's precedent autonomy. The NIH, for example, allows for the use of ARDs in the US, and regulations are in place in Canada, Australia, and Switzerland. But although ARDs are legally allowed in these countries, the uptake still remains rather low. So this brings us to the German context. For highlighting the relevance of ARDs for affected individuals, relatives, and also healthcare professionals, it is important to consider the recent changes in German legislation of the German Medicinal Products Act. So in November 2016, the fourth act to amend drug law and other regulations was passed by the German Bundestag. And this adapted the German law to an EU regulation. So with this amendment, group benefit research involving people of age who are unable to give informed consent will be permitted under certain conditions. And one of these conditions is that a study participant must have previously prepared an ARD in which he or she agreed to participate in the study. Operationalization of the amendment is complicated, as it is dependent on the functionality of an EU portal and the corresponding databases. So meaning that the regulation is for the most part not yet enforced and applied in clinical practice. However, it is expected that it will come into force within 2020 or 2021, and thus it is pressing to provide guidance on how this law should be operationalized in current clinical practice, and especially if it should be operationalized in a patient-friendly manner. The perspective of those with cognitive impairment are important, especially for gaining insight into which factors may contribute to the acceptance and also the use of ARDs. And of course, making sure it actually is an ethically sound tool as anticipated in theory. So to date, there's a lack of empirical studies on affected people's perspectives. And in our study, we investigated what would motivate people with subjective or mild cognitive impairment to draft an ARD and what they would need to do so. So we conducted a semi-structured interview study with 24 persons with cognitive impairment. The results I will present to you shortly refer to the following questions of the topic list. How do you assess the introduction of ARDs? Should anyone besides you be involved in drafting an ARD? what is a good time to draft an ARD, and what would assist you in drafting an ARD. The participants were aged between 45 and 85 years, and there was an even distribution of gender. Interviews lasted between 16 and 80 minutes, with an average length of 42 minutes. For the qualitative analysis, we used thematic content analysis. So the inductive analysis combined methods of close reading and constant comparison to identify emerging themes. And the process was assisted by the scientific software Atlas TE. So in the following, I'll present to you our 3 most prominent results, focusing on general attitudes towards ARDs, necessary conditions, and remaining worries. So let's start with attitudes towards ARDs and research participation. The large majority of the interviewees had a positive attitude towards ARDs and provided a number of reasons supporting their assessment. Several interviewees considered ARDs an instrument to make their own decisions regarding consenting to or vetoing research participation. And people without a partner seem to feel more positive about the introduction of ARDs. Since the new regulation will enable participation in non-therapeutic studies tied to the condition of an ARD being in place, several interviewees reflected on the desirability and consequences of participation in such research studies. So some argued that it is important to help others by participating in research, or that they value scientific research. Some interviews went further and argued that it is more important to help others than to benefit from research themselves. A few interviewees stated they would be willing to help others as long as research is not burdensome. However, some participants also had negative or ambivalent attitudes towards ARDs because they didn't want to make anticipated decisions or felt that they could not decide for a situation they have not experienced yet. So here I see some parallels also to the last 2 talks yesterday. Several conditions and circumstances were mentioned that could assist the drafting of an ARD. So the question arises, who should be involved? Some interviewees stated that they would be able to draft an ARD on their own. Overall, with people with SCI uttered more often the preference to complete an ARD on their own when compared to people with MCI. Nevertheless, a variety of people who could be involved in drafting an ARD were mentioned. So most interviewees desired to discuss their ARD before completing it with a clinician, and argued that either the GP, or a neurologist, a psychiatrist, would be the most suitable for motivating a patient to complete an ARD, due to their already existing doctor-patient relationship. Few interviews also said that researchers themselves would be suitable to ask about ARDs because of their relevant experience and expertise in the research field. Furthermore, several of the interviews regarded it important to discuss an ARD with their children or partner, so for a well-conceived ARD with higher interpretability. The question arises, when is a good time to draft an ARD? Several interviewees argued that the best time to be motivated to draft an ARD is when one is still healthy. So maybe preventative research is still beneficial at this point, and only when one is healthy, one can make up one's own mind in peace. A few interviewees mentioned that it's best to draft an ARD shortly after receiving a diagnosis, because first one needs time to digest the diagnosis and to think about possible participation in research. Others mentioned that actually directly at the time of diagnosis would be a good time. It was also argued by a few that information about ARDs should be available when one is younger, so through public campaigns or the media, or also health magazines. Sorry. The last point was what preconditions should be fulfilled by health providers. Trust was mentioned by many of the interviewees as being essential for drafting an ARD. Trust, it was argued, is based on knowing the professional, by relying on medical expertise, or by ensuring that the professional has no conflict of interest. Furthermore, it was stressed that it was important to have sufficient time to draft an ARD, also to discuss the different meanings and formulations with a medical expert, and to be able to ask questions about different types of research, which can also change over time. It was also addressed by some that it would be helpful to have a pre-formulated template for an ARD, because most found it difficult to formulate their individual wishes regarding research. Further safeguarding was proposed by requiring that a representative was there to monitor research once an ARD was in use. So several interviews also expressed remaining worries and questions. Some worried that they would not be able to withdraw from research once having completed an ARD, and argued that withdrawal had to be possible even after consenting with an ARD. Further, some feared that abuse in research could not be prevented with an ARD. And they said that an ARD would not provide sufficient protection for potential abuse. So the need for protection was not only mentioned regarding participation in research as such, but also regarding the use of the collected data during research. A few interviewees also questioned on a more organizational level whether physicians and other staff will be trained sufficiently to deal with ARDs. So this study indicates several factors that can motivate people with cognitive impairment to complete an ARD, and also that preferences, assessments, and remaining worries vary regarding ARDs when you ask people who may be the target group of such ARDs. And well, other studies on ARDs have focused on healthy adults. We focus on cognitively impaired people's perspectives and their assessment of the use of ARDs. So researchers and clinicians will have to adopt ARDs in their clinical practice, as these will be increasingly implemented in Europe. So you can ask, what are the recommendations that follow from our empirical study? We can say that overall ARDs are considered acceptable as a tool for consenting to research, but require expertise of treating physicians concerning dementia research methods, such as prospective scenarios to support patients and research participants. And clinicians need to be trained to accommodate patients and research participants' fears and needs for sufficient and adequate information. Talking about ARDs entails talking about the anticipated course of the disease, so including losing the ability to provide consent. And as mentioned by many of our interviewees, physicians should take time to talk to their patients and also their relatives or caretakers, who are often overwhelmed by the diagnosis. So we see that this poses quite great challenges for the daily routine of hospitals and also outpatient clinics, necessitating practical adaptation. So as interviewees stated, a standardized pre-formulated template would be helpful for drafting an ARD. And such templates are currently not available. So this addresses the urgent need for more translational and implementation research, as standardization risks that the document's individual characters lost. Templates should be developed to allow for individual wishes and adaptations. So there is a need for further safeguarding. The role of a legal proxy or representative remains important as a functional safety measure. And there's a further need for spread of information on ARDs and provision of practical support, for example, by including social workers. And lastly, it would be interesting but also helpful to have further studies testing motivational approaches that take cultural differences into account. Here I just have a template that we developed on the basis of available examples, especially based on one from the University of Rochester. And here you see it's both the English and German version integrated into one, but this is what we used during the interviews to make more clear to the participants what such a directive could actually look like. So thank you very much for your attention. I look forward to any questions or comments.